Good morning, everyone, and thank you, sir. My topic of presentation is what is cross-linking. So I will be covering basics in this 15 minutes presentation. So cross-linking is basically formation of covalent bonds between the lysine and hydroxylysine residues of two collision molecules or microfibrils. It can be intermolecular, intramolecular. Also, there can be formation of covalent bonds between collision molecules and extracellular matrix proteins. It improves the mechanical strength. Naturally, it occurs as a process of maturation in collagen fibers. It can also be induced by chemical catalyst, heat, pressure, and radiation. So cross-linking has two major pathways. One is enzymatic cross-linking that is mediated by enzyme lysyl oxidase, which is naturally present in the corneal stromal tissue. And another pathway is non-enzymatic, which is basically because of glycation of the lysine and hydroxylysine residues of collagen microfibrils. It happens in cases of aging and also pathologically in diabetes. So if we look at the basic concept of cross-linking, what happens is in presence of UVA light, riboflavin molecule excites itself into its singlet state, later on into the triplet state. And there are two photochemical reactions that take into place. Type 2 photochemical reaction is oxygen mediated that leads to production of reactive oxygen species. And after that, there is type 1 photochemical reaction that is anaerobic pathway that leads to generation of riboflavin free radicals. Ultimately, that leads to formation of covalent cross-links between collagen microfibrils, also between collagen microfibrils and proteoglycan molecules of extracellular matrix. So corneal cross-linking, starting from the experimental studies and how the Dresden protocol was established, I will cover the brief historical perspective here. So cross-linking already we can see physiologically in cases of blood clotting. It already well-established procedure in cases of polymer chemistry. It was used previously in production of filling materials in dentistry. Apart from that, also it was used in prosthetic heart valves to improve their biomechanical strength. In 1990s, there was an article published by Malik et al. On aging of human corneal stroma. They studied the structural and biomechanical changes of an aging cornea, and they found out that there is non-enzymatic glycation of collagen that leads to the cross-linking. It is a non-enzymatic pathway. And also there was age-related growth of collagen fibril diameter. There were few other studies that showed that these aging phenomena, they increase exponentially in diabetic patients. Further, Spohr et al. In 1998 published an in vitro study on induction of cross-link in corneal tissue. This was a study on porcine corneas. And they used variety of photosensitizer as well as various wavelengths of UVA light as well as visible spectrum to check which combination works the best for corneal cross-linking. And they demonstrated that mechanical stiffness of the cornea can artificially be increased. In this study, they used riboflavin 0.5% concentration in presence of UVA light wavelengths 254 as well as 370 nanometer and visible spectrum light. Later on, Wolensek et al. Published their findings on in vivo cross-linking in moderate to advanced keratoconus patients. And they used riboflavin 0.5% concentration in presence of 370 nanometer UVA light. And they found that progression of keratoconus was stopped in all cases. And regression with a reduction of maximal keratometry reading and refractive error was noted in up to 70% of treated eyes. So what are the components of cross-linking? So cross-linking is basically consisting of UVA light and a photosensitizer, which is riboflavin. And presence of oxygen is fundamental in this reaction. So UVA light spectrum we use of 370 nanometer. Why? Because the absorption peak of riboflavin, it coincides at 370 nanometer. Also, it is safe for endothelium. if we go for a shorter wavelength, that may cause cellular damages to the DNA. And if we use the longer wavelengths, that can be harmful for the underlying structures like endothelium and lens. So riboflavin is the preferred photosensitizer in cross-linking. We commonly use 0.1% riboflavin 5-phosphate with 20% dextran or HPMC, depending upon the corneal thickness. In cases of transepithelial cross-linking, which are many studies have been published, we use transepithelial dyes in combination with riboflavin 5-phosphate because to improve the epithelial permeability to riboflavin. So these, for example, benzalkonium chloride, topical anesthetic, trometamol, sodium EDTA, these are being combined with riboflavin to increase the permeability of corneal epithelium by weakening the tight junction barrier of the corneal epithelium. Another method is iontophoresis, which is nothing but basically application of low-grade electric current over the corneal stroma that leads to increased permeability of riboflavin to the cornea. Once we do the epithelial debridement and after that we soak the tissue with the riboflavin, we can actually see it clinically via the slit lamp that riboflavin actually diffuses into the corneal stroma. And after that, exposure of UVA radiation is being done for the cross-linking. So role of oxygen is very fundamental during this process as it leads to free radical formation that catalyzes the cross-linking between collagen fibers. Because of this reason, in cases of transepithelial cross-linking and in accelerated cross-linking protocols, because epithelial debridement, if not being done, that may lead to decrease in depth and strength of cross-linking. What happens after cross-linking procedure is done, there are few morphological changes that are noted in the corneal stroma. Most important reason for increasing the corneal stiffness and rigidity of the corneal tissue is increase in collagen microfibrillar diameter as well as decrease in interfibrillar spacing because of the cross-linking. Other factor which is noted is intense keratocyte apoptosis in the anterior stroma, which happens in the immediate post-operative period. And usually the keratocyte population starts repopulating after 2 to 3 month post-operative period, and it returns to the baseline level after 12 post-operative months. The damage to the keratocyte can be appreciated clinically by mild stromal haze that is in proportion with the level of stromal cell death. And also clinically we can appreciate it in the form of demarcation line, which forms between the irradiated and non-irradiated stroma. In cases of conventional cross-linking, it usually forms somewhere around the depth of 250 to 300 micron. And in cases of accelerated and transepithelial protocols, demarcation line is usually somewhere around 150 micron depth. What are the indications of cross-linking? So it can be basically divided into ectatic and non-ectatic reasons. So in ectasia, it can be primary, जैसे कि keratoconus or pellucid marginal degeneration. Secondary, it can be post-LASIK ectasia. Other indications are bacterial ulcers, corneal melt, and corneal edema. So once there is keratoconus patients, how to proceed in such situations? Most important factors are corneal thickness. In cases where corneal thickness is 400 micron or above, we can proceed with isoosmolar cross-linking. But if the corneal thickness is less than 400 micron, we can proceed for hypoosmolar cross-linking, but with caution. Second most important factor on the timing of cross-linking is age. So in cases of adult patients, documenting progression is required because as we know that cross-linking is being done to halt the progression of keratoconus, it is not required for already stabilized cases. In cases of children, because it has been well established that progression happens rapidly, there is no need to document the progression. Only in cases of doubtful cases, we may do the frequent follow-ups. Otherwise, at first visit cross-linking can be done in cases of pediatric population. As younger the child is, higher the chances of cross-linking failure, so they might require repetition of the cross-linking in future. Now, how to define keratoconus progression? There was a study published, Global Consensus on Keratoconus and Ectatic Diseases in 2015 by Gomes et al. And they pointed out few points on steepening of anterior corneal surface, steepening of posterior corneal surface, thinning or increase in the rate of corneal thickness change from periphery to the thinnest point. There were no quantitative data as it cannot be extrapolated generally because there are various machines available based on Schimflug or OCT based devices, and they have their own indices, so the data cannot be extrapolated in general. Only recommendation here is that whenever we diagnose keratoconus based on any Schimflug based device or OCT based device, the diagnosis and further follow-ups should be done by the same machine, and they have their own keratoconus screening indices, and progression can be decided based on changes in those screening indices. For example, in cases of Pentacam, we have BAD-D. In cases of Cirrus, we have keratoconus screening indices where we evaluate KVF, KVB, and SIF, SIB, and also higher order aberrations. After establishment of Dresden Protocol, there were various attempts on optimizing the outcomes and minimizing the side effects. There were accelerated protocol, accelerated cross-linking by varying the treatment time based on Bunsen and Roscoe law of reciprocity. Other than that, there are transepithelial cross-linking to minimize the side effects related to epithelial debridement. There was customized cross-linking where we do the graded cross-linking, which is localized on the cone area. There is also cross-linking can be combined with PRK and PTK for refractive correction. It can be combined with ICRS, and there is PAC cross-linking for infective keratitis, particularly bacterial ulcers. There are some contraindications of cross-linking. For example, pregnancy and breastfeeding patients, prior herpetic infections, active ocular inflammation, severe central or paracentral corneal scars, autoimmune disorders, poor epithelial wound healing, as in cases of neurotropic keratitis. Corneal thickness less than 400 micron was initially a contraindication, which is now a relative contraindication. We can proceed with hypoosmolar cross-linking, but we have to be cautious, avoiding the endothelial cell damage. So the next presentation will be done by Dr. Ankit Devkar about the Dresden Protocol. Over to you, Dr. Ankit.